Okay. Thanks so much for the invitation, and I hope everyone's having a good midday today. And I'm going to talk about opportunistic screening for diabetes using AI to read on, applying AI to radiology images. I made this talk mainly for more of like the clinical person. So if you're a big AI researcher, this may not be as interesting for you, but this is because I won't be talking about the models and all those things, the more technical details, because I wanted to keep this as a bigger picture. And really, hopefully, we'll have a good discussion here towards the end. So, just starting off here, my disclosures are mainly around service to several radiology societies and grant funding that is around artificial intelligence. And but now I'm not going to be talking about any products. So I'm going to start off, even if I said I'm not going to discuss much about AI, I want to start off by giving a brief overview of deep learning because, you should read these papers and at the end of this talk, you should be thinking, wow, is this real? Like, is this even possible? Because that's the rigor and the call to action that we need to be thinking about this era of opportunistic screening. And I can tell you that this is going to be one of the hottest areas of this year. When you think about AI, yes, there's the GPT and the chat, the large language models, but this opportunistic screening, almost every patient in the healthcare system has a form of imaging, and we can use it to tell us things that radiologists are not, aware of. Is really, I think, often a very exciting way to think about application of AI. So then I'll describe the specific project on AI. And then I'm going to end by sort of just giving a preamble of what's coming down the pipeline from our group. So what is now there's another chart that I use for this just because of the large language models, and I'll be talking about that. But artificial intelligence is the concept of making computers have senses like human beings, and so they are mirrored towards sort of like the brain, how we learn, and so you'll see most of these things are based sort of like understanding of neurology, or at least try to think about it. But that's being challenged today in the next generation of architectures. But fundamentally, you want the large language model, if you gave it a humanoid point of view, that it can hear you, it can understand you, it can speak to you. So it can smell in the ideal world. So you're trying to make it have senses and interact with it. And so machine learning is one way of doing that, and deep learning specifically. So machine learning tends to be used for more of the traditional ways of doing that, but deep learning is a specific way of training these models using large amounts of data sets. So the picture I'm showing here is of Mount Kilimanjaro. This is a mountain that separates between Kenya, the border of Kenya and Tanzania. And if you love to climb mountains, then, or you like to take journeys, you could say, well, I'm not just going to follow what the GPS is saying. And what if you're, the first person to take a step? And what you end up saying is that there have been 50,000 people who've climbed Mount Kilimanjaro. And once those 50,000 people, they have Apple Watches, they have Fitbits, they've really mapped, they're very meticulous about like those people who map all their running schedules, and all this data is available. And so you could say, well, my target is to get to the peak of the mountain, but there are many ways to get there. Some people find that maybe based on the time of the year that you should use this one slope, maybe because if you're climbing in the morning or the evening, depending on the weight you're carrying. So there are all these variables, but you don't know all those things. And so the way that you end up training this model is to say, here is the truth, and here is the data set that tells that I know these people have climbed the mountain, some successfully, some unsuccessfully. And I want you to learn what are the characteristics of the people who've been successful. And when you give me a suggestion, for example, there's a rock somewhere that lions usually stay on, and now you take me through that route, I'm going to penalize. And you have this algorithm that tracks these changes, and that's why you'll hear things like loss function, epochs, batch size. All those things are fundamentally trying to say, how do I load all these 50,000 journeys to tell me what's the effective way to get to the mountain, and penalize the model when it's not it misguides me, but also is, you reward the model when it's in the correct way. So you start off with data and answers, and you give the machine learning, you don't tell it this is the right direction, and then the machine learning is supposed to come up with the rules. And so if you think about imaging data, if you think this is a picture of Abraham Lincoln, this is represented by numbers. The lighter numbers tend to be more of the light spaces, because ultimately this has to be loaded on a machine learning system, and then the darker numbers, and then all you end up with is with a grid, and based on what you're doing and calculations, then you're able to figure out that this is a picture of a face or whatever it is. And so these layers, you'll hear this type of deep learning network. So if you want to say, is this a dog, bird, or a cat, you start off, feeding this as numbers into your machine learning system, and then you end up learning maybe rudimentary layers down here. But as you keep moving on, that process of learning the right journeys, it starts to say, okay, I kind of see that this is a head, or this is a head of a cat, or this is a head of a dog. And that's the difference between all of them. It's not the textures. And sometimes, because we never have all the right data, even medical imaging, we start training these models using pictures of cats and dogs, but we change these final layers to say, okay, now just learn what pneumonia is, or what is not pneumonia. So if you think about that example, this is what we did with this work. We trained a convolutional neural network, but by fast learning, before we started this work was trying to say, we were observing that the patients with COVID-19, they had much severe disease, especially on their radiology images. And we were trying to figure out, okay, could we even get a sense of what was going on? The social deprivation index was not enough to explain these differences. And so we started focusing on a hierarchical condition category codes. As a radiologist, I'll tell you that every time I used to see HCC, I used to think it's hepatocellular carcinoma, but these are intelligent groupings, especially for value-based care. And while it's done mainly for payment, but it sort of groups things, for example, diabetes with acute complications, diabetes with chronic complications, diabetes without complications, trying to bundle payment models. But if you have a good clinical documentation teams, because if you've used ICD codes, you know how messy those tend to be in the healthcare system, then you can start to group them and have a bigger picture that this is, for example, a patient who has, vascular disease, or, a bigger, a more specific disease combination. And so we use these HCC codes, and we chose our initial cohorts were 2 cohorts. One was an ambulatory cohort. These were from the Chicago healthcare system, and a hospitalized cohort. And, this is just showing the patient flow. But the essential thing here is to say we were trying to figure out what's the difference between these patients with COVID and these ones without COVID, and could we learn them from just their images? And we trained up training an AI model that we were feeding that these were the truths, type 2 diabetes, morbid obesity, congestive heart failure, arrhythmia, vascular disease, COPD, and then also giving the BMI, the age, and a risk adjustment factor, that's from a payment point of view, and an A1C, and trying to say, give us the probability of these predictions. And initially, the first round of the model was just getting in, 6 conditions, based on the diseases, and then giving you a probability. So these were classification tasks. And, for this one, you can see, for example, there's a higher, probability of something like this at 70, or this is a 73-year-old based on the AI, and so that was the initial test. And then we found out that, when we were trying to figure out the disparities, was that patients who were Black or Hispanic, patients who did not speak English, and who those two had a big higher odds ratio of having severe COVID. So this was interesting to us, because you can understand why, if you don't speak English as a first language, why there could be a missing code in the electronic medical record system. Because if you've had to use those mobile translation things, they are a pain. And if you have to take history for 1 hour, you just focus on what the patient is presenting with. And so you can see why that would be incomplete. And, and so we started finding, maybe we can start to figure out that these chest x-rays can have some more information, more than what the radiologist is really looking at. And so this set of, the downstream work that would end up coming into opportunistic screening. So in medicine, the definition would be exercising prevention through an unorganized program or a chance encounter. So for example, in patients who get dialysis, they interact with a healthcare system of some form 3 times a week at least. And so what can you do when you touch those patients? You'll find that safety net hospitals tend to maximize when you come in for your primary care visit. They want to do everything. They don't want to go back and schedule you to things to come back later. We see this, for example, in radiology, the practice of systematically leveraging imaging data that are incidental to the clinical indication for obtaining the study. So when you're getting chest pain, you're not really saying diagnose diabetes, and that would not be the appropriate way to diagnose it. And so again, coming back to here, we ended up with a model that we improved on by including and formulating the diabetes cohort a little better. So are we saying that you should use chest x-ray for diabetes screening? Absolutely not. Here's the US PTF recommendation for type 2 diabetes screening. A grade B recommendation for the population should be asymptomatic adults aged between 35 to 70 years who are overweight or obese. And you should give, you should offer or refer patients to effective preventive interventions. And if you look at the catchment area here, it's around 61% because 35% of patients are overweight and 27% are obese. But when you think about BMI, it's a limited biomarker, which is what we would be using for referring for additional screening. So if you look at these celebrities, their BMIs would be in the obese category. And there has been sort of this challenge of just thinness and, relationship with cardiac disease. I think this is mainly being even the thin phenotype. There's a recent paper now this week, I believe, not last week, on Asian diabetes in patients who identify as Asian, and even just trying to be more granular about these broad justifications. And so we ended up with 3 data sets. The Emory one is the external validation cohort. And the only thing to take away here is that we had a retrospective cohort, because remember I started off by saying that you need a lot of data for training these deep learning models. And so you're not going to prospectively collect the data. So this was collected over 11 years from Dooley Healthcare System, and then used to train that model that I showed you. But then we now took the trained model and prospectively validated it in that system. So every time you have a chest x-ray, you run the model and see, is this patient diabetic or not? And then because AI systems don't tend to work well out of the box, when you send them to a new system, they tend to drop in performance. We brought that model to Emory. We did not retrain it, which would be the fine-tuning, those last layers, trying to say, okay, here's how images look like. So we didn't do that. And then I tried to see at a snapshot what the Emory results are. So can AI predict diabetes? We had the AUC values. So you can report many classification metrics, but I will be reporting mainly AUC values for the results here. And you see that these are patients without type 2 diabetes, and these are the patients with type 2 diabetes, and this is the model score. If you have a low score, that's negative, but we see that we have patients who have no type 2 diabetes who have a spread here, have a high score, and this would be the opportunistic screening. So patients who you don't know have type 2 diabetes, but you have some of their images and you can see that the model is saying, hey, here's a high score, and I'll show you a little bit of what this subset looked like. And so
Judy, one second, one question, clarification.
Yes.
But these models include BMI, right?
Yes, and I'll show you what.
Yeah,
So
okay. They include age and BMI. Yeah, okay.
Yes. I'll show you one thing that disambiguates that. So when you look at the sort of the types, and here we were referring to poorly controlled as A1C above 9, you can see that the model still changes the scores based on either no diabetes, controlled type 2 diabetes, and poorly controlled type 2 diabetes. And so we observed, at least from the chest X-ray, that we could get a sense of progressive difference in type 2 risk of diabetes. And this 1381, and I'll show you a little more studies for 14 patients, these ones who are in here, were identified by the model as high risk, but they did not have an A1C value or a type or a diagnosis of type 2 diabetes. And so this, we believe, are the ones who present the opportunistic the potential for opportunistic screening. And out of this 1381, 147 would not have met the criteria for screening, which, because their BMI was 25, less than 25, and 70 did not have any available BMI recorded in the system. So, when we look at this 1381, we saw that what happened prospectively, we saw that 21 of these patients subsequently had a diagnosis of type 2 diabetes, and 205 of these patients got, this is based on the ICD code, and then 205 got an A1C, and 20 of them, their A1C was more than 6.5, and 69 was 5.7 to 6.4. The rest were not screened. They didn't have any code or any A1C value. So Venkat asked, did you have diabetes? So we trained 3 models. One is just the clinical model that just has the clinical factors without imaging. And then there's an image-only model where you say, I'm not telling you, the final model does not have the BMI or anything. You're just saying, here's a chest X-ray, here's what you should predict on this. And then you have a combined ensemble model. And this is the logistic regression model for, do you have diabetes or no? You can see race, language, SDI, and these were mainly the more important features. And that's where you can have, you can include BMI to tell you that this patient have diabetes. So you're not really feeding that into the chest X-ray model. And what we notice here is that if the chest X-ray image only model outperforms BMI to tell you who has a higher risk based on the odds ratio of diabetes. So you can see that the chest X-ray image model here has an odds ratio, more than 4 compared to BMI. Again, challenging that BMI is not really it's a variable biomarker to use. And so I mentioned that we trained 3 models. I'm only showing 2 models here to show you the clinical model. So this one does not have any imaging. You're just using the clinical information, and then the chest X-ray model, and representing many different values. But if you compare just the AUC values that we find and different subgroups, for example, patients who have type 2 diabetes versus, yes or no, versus these subgroups of poorly controlled or type 2 with different BMIs, you see that the chest X-ray model overall performs better than the clinical logistic model. But when we combine both of them, then we do have a better model, more than one alone. And we also find that the chest X-ray model even performed better in patients who would not be in the eligible category with a BMI of less than 25. So these models usually don't work well for everyone. And so we look at, is there a difference between male, female, and various race and ethnicity groupings? Now, I do want to caution that the use of race here is a social and legal construct. It's not trying to say that there's a biologic difference. And we don't find a big difference really in terms of different, at least when in the training performance, that there was similarity around performance between race and ethnicity, and just slight difference between male and female, but not enough to be statistically significant. So that model I mentioned came to Emory. Then we didn't fine tune it. We just said, here are X-rays. Here is anyone with an ICD code or an A1C value. Let's see what the model tells us. These are just different pictures from both sides. The C tend to be the Emory ones. This A are from the Chicago system. And our AUC value was 0.77. We do normally expect a drop in performance, but considering we didn't fine tune, we didn't do anything else on the Emory model, this is actually pretty surprising. Now, I think this is one of the bigger takeaways from this work. Like, it's very difficult for you to say, for example, unless you're showing me a chest X-ray that has a dialysis line, I could say, well, maybe this patient is, uh, diabetic, they ended up with end-stage renal disease. So trying to get a complication, it's very difficult. It's impossible really to look at a chest X-ray. I would be guessing to say, and yes, you can tell a sense of the BMI because maybe the patient looks bigger, but it will be very difficult for you to say that, hey, this patient has diabetes, as a radiologist. And so what we do, we end up using this technique called GIF-splanation, and it's like stacking all the images and trying to see what are the big characteristics. Where is the model really looking at? And this is an area for AI that still needs a lot of work. And what we find, it's still around, the sternum here, the sternocleidomastoid muscle, and the subxiphoid area, that the distribution of fat really does matter. It's not just saying someone is fat. And we know this even, for example, I'm an interventional radiologist. Sometimes you see a high BMI, then you go see the patient and you're like, oh, the most of the fat distribution is in a specific body part, and so it's not just about how much adiposity there is, but it's where it is. And this is sort of like the big takeaway from sort of why the chest X-rays were performing this way. So we then looked at patients who had a chest X-ray, and just trying to model a longitudinal data set, in the retrospective cohort. And, just trying to say, what's the number of days between the chest X-ray and the diagnosis for type 2 diabetes? And 25% had here it's just, this is not the prospective cohort, this is just the original training cohort. And 25% had a diagnosis of type 2 diabetes when we look at an 11-year time period, and mean number of days from when they had their chest X-ray to their diagnosis of type 2 diabetes was around 1,000 days. And so for our cohort, at least we knew that quite a number of these patients were diagnosed after their first X-ray. And so when we look at, does this model keep performing well, over time, and these are just AUCs, you remember that 0.77 was like the Emory one, and we find that overall, if you look at that 10-year time period, we still thought that there was quite a lot of good predictive capability. And so these 1381 patients who were identified as high risk, obviously they all haven't had a comeback to the healthcare system. They all don't have an A1C. They all don't have an ICD code. So you kind of, for this opportunistic screening, you have to determine when should you even intervene, and as you can see, my fourth point there, does an early diagnosis change the patient outcome? Or are we going to start having over treatment when we start to think about for example, this opportunistic screening. And this was an outpatient cohort. We never included any inpatient or any portable chest X-rays. These were patients who were just coming, for example, you had a chest pain, or you had just something else. And for the diagnosis of diabetes, we did not use any glucometry data, and that's just a complexity of how to curate data sets. I'm pretty sure members of this of group will have quite a lot of opinions on that. So when I showed you this work for, opportunistic screening, and the reason why I say you have to be paying attention to it, you can read this Eric Topol's blog, I think 2 weeks ago, talking again about opportunistic screening. Here are chest X-ray studies that are saying, look, we can tell you their cardiovascular risk score more than the clinical parameters. Our work here on type 2 diabetes, then this work showed that we can tell you the ejection fraction. That's, I mean, you can see the heart is big, but there's no way that a radiologist can say this is the ejection fraction. There's even work that's not here that is telling you even the valve that is affected when there's arrhythmias, Then you see coronary calcium score. We don't usually report those unless they're pretty obvious in the aorta on chest X-rays. This is someone who's now moving beyond cardiac risk and saying, you have the chest X-ray, it has that upper part of the pancreas. You aren't going to scan the pancreas, but here I can tell you who has pancreatic cancer. And thinking about lung risk, And for us, mammography, and this is work that we do in our group a lot, to think about if women are coming every year and getting mammograms and we see some calcifications, or even before calcifications, what's the cardiovascular risk, and abdominal CTs. And I'll show you an example of the sort of like the next type of work that is happening. So this opportunistic screening, a subset of patients who are maybe challenging that their BMI not being the best biomarker, and at the same time trying to say, look, these patients you may never know them, or their primary care doctor is not thinking about that. Like, how do you make sure that if they touch us into the system and we know just a little bit about them, that we can scale and try to use these medical images to get us information, and what are the constraints that are necessary to make sure that we don't have harm or over treatment. So I started off by trying to give you this story about Mount Kilimanjaro. The reason why you can take those 50,000 journeys, it does not always translate to utility. And here is this shortcut learning, which is a big factor of the work of our group, is super important. So here, if you told an AI system, caption this image, it says, they are grazing sheep. There are no sheep in this image. But most of the 50,000 images that the AI is taught tend to be saying they are grazing sheep. So models tend to be lazy. Here's an example of trying to say, tell us if this image has pneumonia. The model learns these L markers, the radiopaque markers in chest x-rays, and says, oh, it turns out that this type of image is usually from the ICU. I've realized that the ICU has 16% of pneumonia, or most patients have pneumonia, and then it just predicts pneumonia. It doesn't really learn the pneumonia, it just learns that this patient is in the ICU, they have a higher probability of pneumonia. And so this shortcut learning is a big challenge. So we don't know, is there a characteristic difference in the way we diagnose type 2 diabetes that can be picked up by the deep learning models, that is, that fundamentally could end up not being a biologic difference that the models are realizing in terms of type 2 diabetes, but it's because it's being fooled, or it's being lazy and learning a feature that's not obvious to us as physicians, but it's able to pick that up, and that's why we still see a good prediction. And these papers, most of them are maybe a few haven't been done in our group, but we see this paper I described a little bit of trying to figure out those atherosclerotic, and cardiac disease groupings and the outcomes for COVID. There's a form of biologic age. There is, on these two papers, and this work from UCSF that is trying to predict healthcare expenses. And our work that showed that you can tell the self-reported race of patients from their images. So I cannot, if you give me chest x-rays, I can tell you the patient is Black, they're female, this is their chest x-ray age, which tells me they're aging faster. I won't tell you the specific social deprivation index or the zip code, but I can tell you a sense whether they live in a deprived area or not, and that their diagnosis is going to include diabetes, COPD, and they're going to cost this amount to the healthcare system. And so to me, when I think about this work and why Emory is well posed, we're using the same thing, actually. This work is completed, and it's not published, and so we've used the same models to say, tell us about progression of end-stage renal disease. And what's interesting, you'll know that patients who have end-stage renal disease, we start to screen them at CKD3, and usually you have to get the albumin creatinine ratio in urine, so it requires a 24 urine collection. It turns out that it's actually very difficult to do, and most patients don't get it. And if you sort of look at our distribution of patients and sort of like the progression, if you look at trying to build a predictive and survival model, just using the chest x-ray generated features versus the clinical features, we're finding that it's actually surprisingly good, and we have an opportunity again to catch an opportunistic group, patients who have rapid progression of end-stage renal disease, or patients who are in stage 1 and 2 who would not actively be screened. We did do a trial. We're not there yet. We use Sectra as our PAC system today, which is our database for imaging, to try and do a silent trial where you're not giving these results, but every chest x-ray in the system is run through the system to see who ends up, like that prospective cohort, trying to show that, and obviously an opportunity to design a clinical trial to do the same. If there's any ophthalmologist or anyone doing retinal scans, we're very, very interested in merging, because we do know that the deep learning models have shown not just telling you who has diabetes, but even thinking about progression of diabetic retinopathy. And we should merge these sort of two data sets and start to really show like amazing work and try to figure out the clinical utility. We got an R1 grant last year, and it's not going to look at diabetes, it's really going to look at cardiac risk. But you remember I said location matters for the fat, and right today it's easy to do a whole body segmentation. This is not a hard task, just based on the architectures that are there. You can get pretty much the visceral fat, you can get the muscle distribution, muscle density, muscle, subcutaneous fat. And so merging those two findings, we can get a better sense of a phenotype of patients and how to think about patients and their fat. So this is sort of like what we're thinking about and what was the takeaway. In summary, I would say that to me, you should not just think about this is diabetes. This is an example and it was done here, but it's this opportunistic screening, but it's really fundamentally based on how the deep learning models learn, with a big caution that it may not always learn the underlying disease. It can learn many, many, many things. It can learn even the type of hospital that the patient is coming from. And those, we still don't know how to mitigate those. That's one of our contribution to the AI for healthcare here at Emory in our lab, and how to think when you think about all the scientists who are here thinking about diabetes, who've worked for many, many decades. How do we apply the science and the knowledge with this new tool to make sure that we can scale treatment and access of this disease? So thank you very much for the invitation, and I hope that you did learn something new.
Okay, so if we have any questions, I think Judy is ready to take them. You can unmute yourself and ask your question.
Yeah, I think I have questions, but I saw Nia Johnson's hand up. Nia, do you want to take the first question? No? Nia? So do you want me to ask the first question, Wendy? Or
yes, go right ahead, Venkat.
Yeah, firstly, Judy, fascinating presentation, very thorough work. So I'm going to start my first question with your final slide, that you are trying to look at systemic diseases through chest radiomics. And there is in the audience here, the Saujanya, who's looking at using oculomics. She's looking at the eye as a window to the thing. So the question is, I like the way that you thought that combining these measurements, would be an interesting place, whether they pick the same subset, different subset, are they complementary? So, I would like you to at some point, connect with Saujanya. She's on the thing. She might have a question too. That's something, because she's doing a little pilot study on the same topic, on oculomics, both to detect diabetes and then the next. So, which leads me on to the next question. Your X-ray, you looked at diabetes overall. Okay, so what
we did exclude type 1 and gestational diabetes.
Yeah. But I mean, even within type 2, there is now increasing attention to different phenotypes. Some of the phenotypes are insulin resistant, obesity driven. Other ones are insulin deficient, driven by maybe poor beta cell function. So for that, maybe you need a larger population, maybe a population of African immigrants, or a population of South Asians or in South Asia to get there. So one of the opportunities I want to offer to you is speak to Wendy. Dr. Mohan is going to be visiting here from India in June. You want to set up an hour. He may have chest X-rays on several hundreds of thousands of people in India. So that's something worth, applying your method. That's something worth doing. And also, I was curious, did you look at whether your model could tell the difference between pre-diabetes and non-diabetes?
And the reason fundamentally is what you're saying, right? The size of the data sets matter. Remember, most people have not been storing images for a long time, right?
Right.
Yeah. So you don't have those type of numbers unless you're merging different things. And I have to say that now when we did this work, we only had like 200,000 chest x-rays. We've gone back. We have a very, 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 very good data set now. It has 1 million chest x-rays. And so to even just, if you pointed me to just even cohorts within the center or people who've worked with diabetes for a long time, who have even bigger markers, I think it would be amazing to start merging those two. And no one else will have this type of information or even,
Absolutely, yeah.
yeah.
Yeah, absolutely. So, I mean, so that's just one final thought is
Mhm.
that you also need to get deeper into, like you started getting there, is what are the mechanisms? I mean, like, the combination of undernutrition, is it reflected in lung size? Is it reflected in areola sizes? And does that predispose to early onset of diabetes, early coronary artery disease? So this is where global studies are going to be important. You
Yes.
should talk to Dr. Arshad Kuyumi. He and a colleague in India called Anurag Agarwal are writing an RO1 to add lung measurements to the CARS cohort. So they want to do spirometry, etc. So this might be a place to, whether if they had X-rays, lung. That's what they're looking at, lung. So this might be an opportunity for. I mean, after this call, let me connect you. I noticed Saujanya has also introduced herself to you in her text. So you two should talk also. Yeah.
Absolutely, yeah.
I see we have a handout from Sharon. Sharon, do you want to unmute yourself?
Sharon, how are you?
Hey, good to see you. I was curious about the RO1 you mentioned, where you're looking at adipose quantity and distribution. If the images that you'll have will allow you also to look at adipose quality, because that's one of the
Quality?
things. Yeah, that's one of the things I've seen in my images where, and if you look at the information on how the lipid size, right, and the lipid structure can change with obesity, for example. But how that gets reflected depending on the image protocol you used, I'm not sure.
Yeah, I think the problem with that will be just the ground truth, like how to I'd be happy to like have your feedback. I know we have another project on this, but like to think about how would you label the data sets, because do you need to maybe even think, if we're thinking about fat, should we look at patients? This is just brainstorming. So should we look at patients who have MRIs? Right? Because MRI is great. It has a fat signal, right? And should we be thinking about MRI and then using that to quantify? And, like this is so new, but the past you had to like have people segment organs. That's not a problem. There's a total body segmenter. Like all our data sets can have all the organs, and you can have like this clinical questions to ask, And so I think the limitation now is just size and trying to figure out how to enrich the data sets with as much granularity, which goes again to Venkat's question of explainability. We have to be very, very careful about like just going out and saying, hey, here you can use this for this, right? Because we still need a lot of explainability on the computer vision, which still is missing when you think. I didn't go into details of known limitations. For example, if you change the order of your labels or how you feed your data set, the saliency maps you see are going to be different. So there's quite a lot of work that needs to be done on that piece alone.
How do you get from small scale to large scale, right? So if you do work where you take some experimental data, right, which you can't do on thousands, right? You could do at the scale of hundreds. How do you translate that information into the large scale data?
Yeah, so and by the way, anyone here who's interested in health equity, we're gonna host our second AI datathon. That's how I know Sharon from the last one. We got to do some work together. We're gonna be working a lot on this type of topics. And so if you remember, we had this engineer we got from Google who was talking about embeddings, and those are very, very interesting. So embeddings is maybe that picture I was showing that has a, Abraham Lincoln and ends up being a number. So if you converted all your images, right, to an embedding space. So for example, if we work with Sujanya and come up with our radiology chest X-ray images and the like the retinal scans, then you start to look at these features. I think that is one way that people are going to be able to learn with small data sets. The other one is a lot of money is being put on these foundation models, which means is like training how you go to nursing school or medical school and you learn all these things that you don't think you'll ever use in your life. But ultimately, they serve as a base for you to get just another skill at the top and become a surgeon or something like that. So what people are doing with them is saying, I want to get the embedding space, and if you have a foundation model that you can easily train, and maybe that's going to translate. So pretty early work, but that's how people are overcoming these data sets of limited sizes and how you use them and then translate them to the real world setting.
That's great. Yeah, I'd love to talk more about the adipose quality, because I might tie to some of the biopsy work I'm trying to do.
I don't know if it's a good sign that we're ending early or people do not. I think it's interesting. For sure, I'm gonna get a lot of contacts from Venkat, so I've enjoyed.
Yeah. No, I think this is phenomenal. I think, that the nice thing is, this is an interesting thing. Chest X-rays, like EKGs, have been
Yes.
routinely done.
Yes.
And I don't know whether you remember the debate 10 years ago in the UK and etc. People even argued that doing routine chest X-rays is a waste of time. You should not do it anymore.
Yeah.
Because the data doesn't show anything. So now you're sitting potentially on a whole library of chest X-rays, if you really, and people that don't even see the value of it. So you should think in terms of creating a center for chest X-rays where you assemble data from across the world on available chest X-rays, put them through, all kinds of, deep learning, and who knows? The future of medicine might just be your office, that people just come and go.
Yeah.
Again, I think if you should. My suggestion to you is reach out to the places that might have chest X-rays. The UK Biobank.
Yeah,
So
the UK Biobank is so that all of us don't have enough, right? The problem with these people, not these people, these places is that they're missing like some of the clinical work. So we are one of the groups that has actually most of the most diverse data sets that are imaging based today.
What about NHANES? They must have X-rays, chest X-rays.
The NHANES, I thought it's just the clinical one.
No, check with it. NHANES, and then the other large cohorts: ARIC, Masala, Cardia, Framingham.
Okay,
and then the other one. This is where collaboration with a country like Denmark would be useful, because there's a person called Yanni Nielsen who used to be a visiting professor here. She's in Denmark, and there are other people working with Denmark. They have it's a 5.5 million people with all the clinical records. So this is where your international collaborations will become very valuable for you.
Yeah.
I think you should get out of Emory and think the globe.
That's why I'm coming to you, Venkat.
Thank you. Let's share and chat.
Yeah.
All right. Does anybody have any other questions?
Yeah, I didn't want to do more of the deep, I didn't want to do more on the technical, because I can teach that, I can show you that. I think the bigger takeaway here, is just be aware of the opportunistic screening. Like what's coming down the pipeline is so, to be honest, so outrageous. And if you had asked me even a few years ago, like, oh, would you use voice? People are using voice to screen for diabetes. Like it's a little bit, to be honest, crazy. And you should think about this. It's not crazy science, but we need to not abandon our scientific rigor. We should be using these things to either help us figure out, is it real? Is it biologic? Is it just as an artifact of how we take care of our patients? I'll give you an example with, for example, postpartum hemorrhage. The most important features tend to be delivery on a weekend. And those make sense. The hospitals have the fewest nurses, the fewest people, workforce at night and on weekends. So the fact that these models are able to pick those patterns should tell you a lot about how we will deploy. To me, when I think about the opportunity for example, in AI here, And how our group has been able to succeed is to figure out what's the gap. Like, what are things that only we can do? We are imaging experts, but here, when we have a world-leading diabetes center, is, like Venkat, you're saying, is maybe to build these collaborations and bring new people or new thoughts into what we're doing to accelerate sort of even research that moves forward. I am doing a pretty exciting project around GLPs. That's pretty.
We'll talk
So,
about it,
yeah.
because there's another Institute of Gastroenterology that does, 1,000 endoscopies a day, and we'll chat about it. But there's one more opportunity for you. I'm thinking of places where they do a lot of chest X-rays. Okay, TB centers.
Yes.
Like
Not
there are
only
these
Kenya,
the stop
TB initiative.
yeah.
Yes.
So if we have a TB center at Emory, and they work, so there are many places in India where they do TB treatment. And so there is an association between TB and later diabetes. So if you can get the X-rays from those places and subject them to analysis, these are the kind of opportunity you don't want to, there's data lying around. That's the advantage of the work you're doing.
Yes. Awesome.
And it's data that nobody wants, nobody, they're not going to fight over giving you chest X-rays, that's
No,
the
yes. Awesome.
Okay, wonderful.
All
So
right.
let's reach out and I connected you with a few people. I'm happy to sit
Yes.
down, maybe next, let's set up an hour chat and brainstorm.
Yeah.
And quadruple the amount of work you do for you, happy to do that. Yeah, see you later. Thank you.
No, thank you so much. And thank you everyone for listening patiently, even if it's Judy being mentored, but yes, this is the best ground rounds to give. Yeah.
Thank you.
Thank you so much. Thank you so
Awesome.
much, Judy, and thank you everyone for attending this EGDRC seminar series.